welcome back to another insightful episode of MedSynapse podcast series. I'm Hetvi Shah, your host, and today we are diving into a topic that affects many globally, which is gastrointestinal cancers. These cancers, which can strike anywhere along the digestive tract, represent unique challenges in diagnosis and treatment. And to guide through these challenges, we are thrilled to have with us Dr. Kartik Kulsheshthra, a highly skilled surgical gastroenterologist with over 8 years of experience in this field. He's currently practicing at Apollo Hospitals in Kerala. Dr. Kartik's expertise spans a wide range of gastrointestinal conditions from common issues like acidity and irritable bowel syndrome to complex disorders such as inflammatory bowel disease and bladder cancers. And he is here to share his insights on the latest development in the field and what they mean for patient care. So thank you for joining us today, Dr. Kartik, and it is an absolute pleasure to have you here today.
Yeah, hi, and thank you for having me on the channel. So I'm Dr. Kartik. I am practicing basically in Apollo Hospital, Kochi. I am a surgical gastroenterologist with liver transplant training, and I have been in Kerala for quite some time. I did my post-graduation from Trivandrum Medical College, and did my liver transplant training from Delhi Fortis Hospital. And I deal with a lot of, as you mentioned, a lot of gastrointestinal complex conditions, which includes obviously benign and malignant conditions of the gastrointestinal tract.
Thank you so much for sharing that, Doctor. Now let's just kick things off by discussing the primary risk factors associated with gastrointestinal cancers. And could you also shed some light on the genetic predispositions and lifestyle factors that contribute to the development of these cancers?
So see, basically you should understand what the gastrointestinal tract means. So when you talk about the gastrointestinal tract, it includes any organ which starts from the mouth up to the anal canal. So it includes your food pipe, which is otherwise in medical terms known as esophagus, followed by the stomach, followed by the small intestine and the large intestine. Apart from this, the hollow viscous organ, through which the food passes, we also have some soft tissue organs like liver, the pancreas, the spleen, gallbladder, and the bile ducts. So the entire thing constitutes a gastrointestinal system. It's a big system, obviously. It has multiple organs in it and a vast area as well, because starts right from the food pipe, goes up to the stomach, and the entire tummy constitutes the gastrointestinal system. So any part of this system can be affected, and you can have malignancies or diseases in any part of this gastrointestinal tract or the system. So depending on the site of the tumor, the site of the cancer. So stomach cancer might be different from a intestinal cancer. So as you asked, the predisposing factors or the risk factors for gastrointestinal malignancies. So in general, obviously, age is the number one risk factor. So as you grow older, obviously your risk of getting cancer is much higher, because the body, age-related changes will happen. Definitely, the age-related cancers will be more. So the cancers of the large intestine, cancers of the colon, cancers of the pancreas, even gallbladder, they happen much more frequently in the elderly age group. Younger age group also, I have seen cases. The youngest I have operated for a cancer is at 24 years of age, but then they are mainly the genetic side of things. Elderly patients more have sporadic cancers. Second, the region which you stay. So, for example, in northern part of India, gallbladder cancer is very commonly seen, whereas it's not that common in the southern part of India. Similarly, pancreatic cancer sometimes is seen more commonly in the southern part of India. There's something called chronic ulcerative pancreatitis, where there are stones in the pancreas, that is more seen in the southern part of India. So again, there is factors, long-standing stones can even lead to malignancy as well. So again, the place where you stay. Then third is diet. So obviously, an unhealthy diet, that can also predispose to cancer, less of antioxidants and more of junk food on red meat, they are contributing to colon cancers. Then again, next coming to the risk factors in the form of habits. So smoking and alcoholism. So smoking is, I think there's no cancer in this world where it is no association with smoking. Almost every cancer has association with smoking. So it's a very unhealthy habit, obviously, it should not be, directly caused. And second, alcohol intake. So alcohol intake is having strong risk factor for liver cancers. So alcohol intake leads to cirrhosis, and cirrhosis is a risk factor for liver cancers. And then apart from the diet, the addictions, you have the genetic predispositions. So some cancers run in families, especially the intestinal cancers, the large bowel cancers. They have specific genes, they have specific syndromes which we have. Like this guy I was mentioning, 24-year-old guy which I operate for a large bowel cancer. He's having a specific genetic condition because of which entire families at risk for having cancers. So, however, these genetic cancers are not very common. They're in some families. Out of the suppose 100 cancers, if you talk about 100 people having cancers, hardly two or three or four will be having gene-related cancers. 90 to 95, 96% are sporadic. Means they have just happened for no reason. So yeah, so these are broadly the risk factors for.
Yeah, that was actually very informative, and I think it is so crucial to understand that how basic lifestyle also change can impact these risk factors. So now let's more talk about the early detection of these cancers. So what are the current recommendations for the screening of gastrointestinal cancers, particularly for high risk population, and how do you approach screening in your practice especially?
So as I told you, we have a large system constitutes the gastrointestinal system. There are so many organs. So depending on the organ that you are concerned with, you'll have different symptoms. So for example, if you take the case of esophagus or the food pipe. So if there's a tumor sitting in your food pipe, what will be the first symptom that you have? You'll have difficulty in swallowing food, right? So that will be the first symptom. So if a patient comes to you with difficulty in swallowing food or not able to eat properly, or he's not able to swallow the solid food properly, then it's a problem. So you have to screen those patients accordingly. Coming to the stomach, again, if there's a tumor sitting in the stomach, it might either cause block there, so you will not be able to eat and you'll be vomiting all the time, or it will bleed and it will cause, you can see the blood in the person vomits the food, or there'll be blood in the stools in the form of blackish stools. When you go down the intestinal tract, you go into the intestines or the colon. Again, there's a tumor sitting there. If it's a big size, it will cause obstruction. Person will be eating food, the food will not be able to pass down. He'll have abdominal distension. He'll have sensation of vomiting. Similarly, these patients can also have bleeding because the tumor sitting there can bleed, and they'll be noticing blood in the stools, which is a very common symptoms. It's often, misdiagnosed as piles or something. So many people say, okay, it's part of your piles or hemorrhoids or whatever, but then inside there'll be something much major sitting there. So we have to be very careful about these symptoms. Now coming on to the other organs like liver. So liver, when it starts a tumor, usually it's asymptomatic because liver is a big organ. Small tumor happening there, you won't even know. So when the tumor grows to a particular size, there will be signs like some pain or jaundice might happen. Pancreatic tumors usually present with, again, they are mostly asymptomatic. When they grow to a particular size, they get cause jaundice. And one common feature of all these tumors is significant loss of weight and appetite. So what I mean by that is when you have a tumor growing in your body, so what it does is it decreases your appetite a lot. So even though you've not had something in the morning, in the afternoon, and the food is kept in front of you, patients usually have aversion to food. They don't, feel like having anything still. And second, significant loss of weight. That means, unintentional weight loss. I'm not talking about intentional weight loss. You're going to a gym to decrease your weight. That's not a weight loss. That's an intentional weight loss. Okay. So unintentional weight loss of more than 10% in the last 6 months is indicative of something wrong going in your body. So you are, you are eating normally, you are, behaving normally, but then suddenly you are 60 kg and after 6 months you become 50 kg or 53 kgs. That has to be, taken a bit of seriousness. So these are the broad, symptoms or of any kind of cancers in your body growing in your body. So now coming to the screening or the diagnosis. So screening, basically, we all know that screening is for people who, to diagnose it early, detect it early. So as you asked me, what is the high-risk population? So high-risk population is depending on the, number one, whether there is a family history. Suppose in your family there is the history of colon cancers. Your first-degree relative or second-degree relative had a colon cancer. In such cases, we recommend that you start colonoscopy examination or something called fecal occult blood test, FOBT, where we check the stools for blood. So it can detect a minor fraction of blood as well. So there's some bleeding happening inside that can signify a cancer. So such things can be started early. Probably at 40, you can have a colonoscopy examination. There are certain syndromes or certain diseases, polyposis the risk of cancer is very high. In those patients, we start the screening at 15 to 20 years of age. Then on familial cancers, suppose someone has a strong history of stomach cancer in their family, they can start endoscopy at 40 years of age. In the
Mm.
normal general population, it's recommended that after 50 years of age, once in 5 years, you can undergo endoscopy and colonoscopy. And obviously, annual ultrasound scan examination is as enough as well. In patients who have a chronic alcoholics, who have cirrhosis of liver, where the incidence of liver cancer is much more higher. In such patients, they can, every 6 monthly or yearly, they can get an ultrasound done. And certain blood investigations that are there, which we can known as tumor markers. So these, when the level of these tumor markers is very high in the blood, it signifies that there might be a underlying cancer. So liver patients can undergo AFP. Colon cancers patients who are suspected to have can undergo CEA tests. So there are some other tests which we can do to screen the patients.
Yes, that those are some very nice diagnostic, and I think that you should never miss out on a warning that your body is giving.
Yeah, exactly. So the problem is whenever the body will throw warnings, okay, the
Mm.
body will tell us, okay, this is something going wrong. It's like a car. You're driving a car, the car will throw some symptoms, but it's up to you whether you want to ignore. You keep driving with the engine light on. So that's not the way. If your body is showing some symptoms, obviously you have to take care of it. You have to, consult a qualified person, qualified doctor, well-trained person who can, check the symptoms and diagnose you and give you the adequate. Because in today's world, there are a lot of treatment options. The medical science has grown a lot. So diagnose at the right time, probably you can have a very good outcomes.
Absolutely, I feel that is such a good piece of advice there, because in the world of social media, everything you just Google it and everything comes. So that is also
Yeah,
something
I think that's the biggest
that.
problem with the social media. Google you Google anything, it will straight away take you cancer. People get scared of it. Yeah.
Exactly. So now, minimally invasive surgery is actually the talk of the town. So, and it has also revolutionized so many areas of medicine. So, how has laparoscopic and robotic assisted surgery changed the landscape of gastrointestinal cancer?
Laparoscopy and keyhole surgeries and robotic surgeries have brought a real big paradigm shift in the field of gastrointestinal surgery, basically. So if you remember 20 years back, 25 years back, if you have to get a small organ removed, like a gallbladder or an appendix, which are basically very small organs, you just need to go in, remove it, and come out. But then for those, you'll have to have a very big incision starting right from here to here. Big incision means bigger complications, more the pain, more the hospital stay for the patient. But actually, in reality, you just have to go in, remove that particular organ and come out without disturbing other organs. But when you're doing open surgery, obviously you're not able to achieve that goal. You're touching everything else. So then the concept of keyhole surgery came, where you just go very precisely with small holes inside, and you go to the target organ, take it out safely, and come back. Surgical strike, as you say. Very common term. So that was possible with keyhole surgeries. And as in the field of startups where so many innovations are happening. So a lot of innovations are happening in medical line as well. So we have now much more advanced systems like a 4K and HD systems, a 3D system where you can see much better clarity when you go inside the abdomen. You can zoom in and exactly see what you need to see, and you can precisely control the blood vessels and whatever organs you want, and you can come back very safely. So yeah, it has caused there's a lot of changes now. I think I don't remember doing a open surgery for a gallbladder or a appendix or even hernias, intestines in the recent past. For years I've been doing only keyhole surgeries. We don't usually do open surgery unless otherwise indicated for the patient. So that much we have changed. And coming to robotic also, robotic has been a big innovation. I am a robotic surgeon. I'm a trained robotic surgeon. We do robotic surgeries in Apollo and Kochi. So again, the precision and the vision that we get in these assisted platforms. We only operate so that the robot is operating. It's again a myth that people think the robot is operating. The surgeons only operate. But then the precision that we get with the robo, see, when we grow up, obviously all surgeons will have some kind of tremor. So you won't believe that this tremor is also, cut down by the robo. So obviously that benefits the patient.
Yes, actually, it is so great to hear the benefits these innovations bring. Especially, it also makes the lives easier for the surgeons as well as the patients.
Exactly. If the surgeon's life is easier, obviously the patient will benefit from it now.
Yes, definitely. So now, when managing gastrointestinal cancers, how do you determine the timing and appropriateness of combining surgery with chemotherapy, radiotherapy, or any kind of immunotherapy?
So see, basically, once so how do you diagnose a cancer? Number one, first is history and clinical examination. Patient walks into your clinic, you see the patient, you talk to them, you ask them a history. Suppose a patient coming with a blood and stools, an elderly patient. You think, okay, fine, this might be a problem. Then you examine the patient, you do abdominal examination, you do a rectal examination. Sometimes you might be able to feel something, sometimes it will be normal. Then you go for the next set of investigation in the form of a colonoscopy or endoscopy, whatever is required. And then suppose in colonoscopy you find a tumor in the intestine. Then you go for the staging investigations. Okay. So one is diagnostic investigation, one is staging investigation. So you diagnose the disease, then you stage the disease. What's 1, 2, 3, 4 stages are there. So for staging, you do a scans. It may be a CT, it may be MRI, it may be MRCP, depending on the organ system. Then once you know the stage of the disease, then you decide on a treatment plan. So all these treatment plans are actually, standardized plans. It's not that, it is as per my whims and fancies. I want to do this, I will do this. Not like that. They are internationally recommended guidelines. They are groups, they are NCCN guidelines. So which is International Cancer Network guidelines, which we have to follow. So depending on the stage of disease, we recommend whether some cancers the treatment is upfront surgery. It's diagnosed in the early stage, and the local spread is not there, and it's not spread far off. The metastasis is not there. You go for surgery, you remove that organ and come out. However, there are some cases where the cancer is a bit more spread out, or it is locally advanced, or metastatic. In those cases, we can't go for surgery first. In such cases, you have to go for chemotherapy first, assess the tumor whether the response is there to the chemotherapy or the radiotherapy, and then we decide the plan. Again, there's always surgeon is not the only one who's involved in this. Obviously, we are a part of a team. It's called the multidisciplinary team, MDT, where surgeon will be there, oncologist will be there. Okay, and it's required some other specialty like a pathologist or maybe some cardiologist if the patient is having some cardiac issues, whether this plan is fit for the patient or not. We sit together, we decide, okay, this plan is good for this patient, and then following all the guidelines, we say whether chemotherapy is done first or surgery first, or chemotherapy first, then followed by surgery, then followed by chemotherapy. There are different protocols.
Okay, so actually, the multidisciplinary approach can make a significant impact. And
yeah, it does. It has always has to be followed because one person cannot take all the shots. It's regarding a life, so the best possible treatment and the cure has to be given to the patient.
Also, I think personalization is also key because every patient might react differently to everything.
Yeah, exactly. See, the thing is, tumor is a very, very strange thing. Okay, the tumor biology, what we call tumor biology. So tumor biology is very strange. So a colonic tumor can present in different ways. It might behave differently in different people. I have seen tumors which are very so aggressive that before you think it just spreads like anything. And there are people who have been living with the tumor for the last 1 year and their growth is very, very less. So it is, so many studies are happening about it. So many, researches are going on to understand this, phenomena, but we are still unable to decode it. But yeah, there are some general guidelines which you have to follow. People have, in the people who research about these things, they make guidelines which are good for most of the people, which applies to most of the people. You have to follow that, give that personalized care to a particular patient, and give the best outcome for them.
Yes, absolutely. I think that is so rightly mentioned by you. So now, could you tell us about some of the most promising emerging therapies in the treatment of gastrointestinal cancers, and what advancements are you most excited about?
Yeah, so see, obviously in the chemotherapy and the radiotherapy side of things, there are a lot of advancements happening. So I'm not the person to talk about it because I'm not an oncologist basically. But then, yeah, my friends tell me that they're very precisely they can go and target an organ and they have to give a radiotherapy. So previously, it used to be you will give radiotherapy to one organ, but obviously it has side effects to other organs. But then the precision is much better now. Similarly, a lot of chemotherapy drugs are coming up which are much more advanced. Even in advanced cases, immunotherapy is coming up in a big way, where even with the most aggressive of cancers, the cancers which spread very fast, or the metastatic cancers also they target very quickly. So that's those kind of things. Surgical, if you ask me, definitely, as I mentioned, robotic surgery where we are able to go into difficult places also and difficult cases also we can operate minimally invasively without making big incisions. And then there's something called 3D printing, which is coming up very quickly, where you can actually 3D print an organ. Suppose tomorrow I have a liver surgery, a cancer of a liver, and I have to operate. And it's not easy. Liver surgery is quite difficult. So when for doctors, we don't have net practice, no. Like in sports, you practice before that. We don't have that. So tomorrow's a case. There's a CT scan. There's a tumor. So I have to go and take it out. So I don't know how good or bad it is going to be inside the patient. So now with the help of 3D printers, you can feed that image in the printer, and the printer will give you a model of the liver. So one day before surgery, you can actually practice it on that model. You can get a rough idea. Okay, might be the thing. This is where the blood vessel is coming. This is how I have to plan it. So yeah, that's a very exciting thing. Now there are reports, and probably it will come in the future where there are some special 3D glasses where you can put and you can operate, and you can see the image super. Like suppose you have the CT fit into that glasses, and when you see the patient, the CT image will show you where the blood vessel is going, all these things. So yeah, a lot of exciting. And then probably this Apple Vision Pro is also the new thing, which while operating you can see the multiple images in the Apple Vision Pro.
Yeah.
So a lot of exciting stuff is happening here.
So a lot of advancements going on, and I think we all are
Yeah.
excited to see what the future of healthcare holds.
Yep.
Now, speaking of challenges, there are always challenges. So, how do you address the unique challenges of providing patient-centered care in gastrointestinal cancer patients, particularly in terms of quality of life, obviously, and long-term follow-up that is necessary for gastrointestinal cancers?
See, I'll tell you my concept. So no matter what surgery do you do, the aim is to make the patient healthy. Okay, the patient should be in a state after surgery that he should be able to carry his own, physical needs by himself, and even financially, the patient should be, fit enough. It's not that he's dependent on someone physically and financially. So that's the first thing that I always keep in mind, because for my patients, my surgery is successful not when the patient is out of the theater. My surgery is successful when the patient is out of the hospital and walking by himself and earning a living for himself and his family. That's what I call a successful surgery. And especially in the gastrointestinal side of things, you have the tumors are so complex, and there are so many systems involved. Obviously, we have to give a personalized care. We have to assess the patient properly. So surgery is not about operating per se. It's just you just don't have to operate. Anyone can operate. Operating is not a big deal. But you have to work up the patient properly. You have to see whether this patient will tolerate the surgery or not. So if you're planning a liver resection, or you're planning a pancreatic resection, whether this patient will tolerate a 6 hours or 8 hours surgery, whether after the surgery will the patient be able to walk again, whether after surgery he'll be able to recover again. So all these things we have to take care. And then planning with the other consultants, like the chemotherapy specialist or the radiotherapy specialist, what best possible treatment we can get to the patient, so that the patient goes home well and happy, and he can lead a good healthy lifestyle.
Yes, I think ensuring quality life is actually very vital in all cancer treatment.
Yeah.
So now, as we wrap up today's session, I would actually like to thank Dr. Kartik for sharing your expertise and your insights with us. And let me tell you that your insights into gastrointestinal cancers were truly incredible, and I am sure our listeners will take a lot from this conversation.
Sure. Thank you so much, and I hope we can have more interactive sessions in the future.
Yes, sure. So before we sign off, is there any final piece of advice you'd like to share with our audience?
Yeah, why not? I mean, as a person in the gastro, who uses gastrointestinal system on a daily basis, I would say eat healthy, have healthy habits, and avoid any kind of addictions. So smoking, alcoholism is a big no-no. There's nothing called good alcohol or bad alcohol. Every alcohol is bad. Every smoke is bad. And adopt a very healthy lifestyle. Exercise daily. That's very important. Get up on time, sleep on time, have a good circadian rhythm, and eat healthy food. Yeah, that will be the most important things.
That's a good piece of advice. Thank you once again, Doctor, for joining us and sharing your expertise with us.
Thank you. Have a good day.
And to our listeners, thank you for tuning into another episode of MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. And remember to stay informed and proactive about your health. Until we meet again.